just a sinking ship, and you're just a pair of lips that I've lost in the moment. All I want is for you to come back. Now I'm caught in the middle of life, and I need you to survive.
Welcome. It is that time, Monday, 5 p.m. Eastern Time. It is Ask Dr. Geier Live. Wherever you're watching, hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, an anti-aging and regenerative medicine expert. I help athletes and active people feel, look, and perform their best regardless of age or injuries. Very excited to be here for about the fourth or fifth time that we've been doing this now on Mondays at 5 p.m. I've really enjoyed it. It's different than doing Friday lunchtime, but I hope it works out for all of you. If you are watching this for the first time and you want to ask a question, a couple things. One, enter your question in the chat, not in the comments, like Omar did. Omar from Tajikistan, he wants to ask a question. Omar, please go ahead and do that. But he is leaving that in the chat. So if you're watching and you can't figure out where the chat is, look for Omar's comment on desktop, laptop. It should be on the right. I'm not sure exactly depending on your phone, but put it there, not in the comments. I cannot see the comments. I'm doing this through eCam, not through YouTube, so I can't see the comments. After the show, sometimes I'll see that people have left questions in the comments, and by that point the show is over, so leave them in the chat. Also, Omar and everybody else, please know I am not giving you medical advice. I am sharing any of this information for information and educational purposes only. I haven't seen you, I haven't examined you, looked at x-rays, MRIs, any of that. I'm not your doctor, you're not my patient. It's not legal to give medical advice across state lines in states where I don't have a license, and certainly not in other countries. So I'm just answering it for information and educational purposes only. So make sure you understand that. And last, any military veterans out there, if you want to ask questions about nexus letters, DBQs, disability claims, things like that, go to my show at 5:30 on the Veteran Nexus Letter channel. I will be there soon and answer those questions. That is a different show, different purpose. Very excited to do that, but that is not the purpose of this show. This is to give you information on injuries, surgeries, recovery, rehab, that type of thing, regenerative treatments, exosome, peptides, anything like that. That is the purpose of this show. I will stick around as long as there's questions. Sometimes it can be short. Sometimes I'll go for 30, 45 minutes, something like that. Just really depends on what's going on. All right, let's go ahead and get started. And I see Omar has left a question, so I will jump ahead even though others have come in since then. But since I teased it, and thank you for joining us from Tajikistan. That is very cool. I've done surgery, meniscus tear, bucket handle, ACL. 1 year ACL is good, meniscus is slightly torn. This is where it is tricky sometimes when I'm not involved. Great news, the ACL reconstruction sounds like did well. I assume it incorporated somebody, patient hopefully got strength back, motion back, the knee is stable. The meniscus, if it was a bucket handle tear and it was repaired, meaning sewn together with stitches, that does have a not insignificant failure rate, meaning that sometimes that happens. It doesn't heal. And what to do about it really depends on how much of it is not torn, how bad is it completely not torn, or is it just a small area, and is it symptomatic? And then if so, can you put another stitch in it, maybe if it's a small area, or do you say, all right, I have to go in and take that whole inner part out? You hope it's not that, because that obviously takes away a lot of the meniscus and then leads to increased rates of arthritis down the road. That's the whole point of repairing certain types of meniscus tears that are repairable. The bucket handle is a meniscus tear basically that can flip back and forth, very amenable to a repair, meaning putting stitches in it to get it to heal, but it can go on to not heal. There's not a great blood supply to the meniscus. Does actually do better in the setting of an ACL surgery than if you just do a meniscus repair surgery without an ACL surgery for blood reasons and healing factor reasons. But what you do about it a lot of times is surgery. But it depends. There's a lot of variability depending, again, on what exactly is going on with that meniscus. All right, where are we here? David Watson, what happened to penicillin polysulfate, xylacil, trials looking good? I will be honest, I don't know, honestly. So I have a few patients, I haven't actually talked to them in a while, that were so impressed with penicillin for their arthritis that they actually knew it was coming. They knew it was in phase 3 trials in the U.S. They bought stock in Paradigm, the company trying to bring it to market in the U.S. And at least a few years ago, when it got fast-tracked by the FDA for phase 3 trials, they are like, I'm going to get ahead of this. I'm going to buy stock and make a lot of money. And from the board, what they told me about the board meetings is it was progressing well. I don't know where that is. They have to be close to, if not done with phase 3 trials at this point. To my knowledge, there's been nothing else released. I will say that this is kind of how phase 3 trials typically go in the drug approval process. We got a little bit spoiled, right or wrong. This is not a political statement, but things don't normally go as fast as the COVID vaccines did through the FDA process. So I assume it's still moving along. I have not heard anything bad about it, and hopefully it will be available through your traditional pharmacies, and traditional orthopedic surgeons and primary care physicians will prescribe it. That gets to a whole other discussion about will they. But having said that, I am still hopeful it gets traditional FDA approval. Having said that, again, there are compounding pharmacies and a handful of physicians in the United States that will prescribe it now as an off-label medication. So I'm a big fan of penicillin for the right patients, for sure. Tang asks, do I ever do phone appointments? I do. I'm a few states away. Yes, but only for people that will be able to come to see me as a patient in my Charleston, South Carolina practice. I only have licenses in South Carolina and North Carolina, so I can't prescribe medicines. I can't do treatments. Obviously, I can't do injections and that kind of thing virtually. But even for somebody that's just going to do medications, you would have to come see me once. And so if that's not possible, then no, we don't typically do Zoom consultations because it's illegal to give medical advice across state lines, as I said at the beginning, in states where I don't have a license. So North Carolina, South Carolina, yes. Otherwise, yes, I'll do a quick one, but that's really just sort of a preview or a quick discussion of what we would talk about in the office in Charleston, South Carolina. More than half of my patients travel in to see me. I had a patient today from Salt Lake City, so yeah, absolutely, we do that, but just for compliance reasons, and you can be mad at me if you want, it is not my doing. It is a federal rule and law, and it is a state medical licensure and state pharmacy licensure rule. That's true for anybody, and if people are doing it illegally, that's on them, but we don't do that. But I would love to help. All right, let's see. Jerry, are you familiar with regenerative protein array therapy? I am not aware of it, but I will try to look it up maybe for the next show. I'm not real familiar with that, unfortunately. Have I ever treated people with rheumatoid arthritis? Yeah, I mean, I do. I will say I do more osteoarthritis because that's typically what comes to orthopedic surgeons. Rheumatoid arthritis, typically treated either, if not by your primary care providers, if it's a specialist, a rheumatologist, because that involves a lot of infusions and immunotherapies and that kind of thing. But having said that, I do have some rheumatoid arthritis patients interested in penicillin polysulfate. So I do get some, but not nearly. I mean, it'd be a small fraction compared to osteoarthritis. And Omar says he's 20. Yeah, I mean, that is typically right. ACL and repairable meniscus tear, that would typically be something you would see in a young patient. Kayvon Alex, drop foot, TB 500 BPC, where should you inject? A couple things. One, and I am not promoting peptides necessarily. Like with any experimental or off-label treatment, I am just giving you information. I am not promoting something that is necessarily off-label. I am not confident that those peptides would be terribly effective for a drop foot if that's what's going on, if it's a nerve-related thing. Maybe it would. I just have not seen any data that would make me think it would be. The where you inject peptides depends a little bit on what you're trying to treat. They are subcutaneous injections, and again, it depends on what. So if it's a muscle injury or something like that, maybe you would want it closer to the site of injury. There are people, though, that think just subcutaneous in the abdomen or glute should get throughout the body. That is a subject of some debate. I tend to like BPC closer to the source of injury or pain, but again, there's some debate about that, and depending on where you did your peptide certification, you may get different opinions, or where the physician did. But drop foot, I can't say that I have any experience with that, and would not. I'd be a little concerned that it might not work. That'd be something the doctor that prescribed it for you, see where he or she thinks you should inject it. Nicholas, why is this not popping up? Dislocated my patella, torn MPFL 14 weeks ago, snowboarding injury. Nice, very cool. No prior patellar instability. Why is the consensus to just do PT after an initial patellar dislocation if there's such a high recurrence rate? Because it works more often than not, and if you can avoid surgery, that's always a good thing. I mean, at least the studies are all different, but the recurrence rate for patellar dislocations less than 50%. The indications typically would be like pro athlete potentially, but more importantly, something else that requires surgery. You knock a piece of bone or cartilage off as the patella comes off. Comes out, you knock off a piece of the bone or cartilage, and it's floating around loose in the joint, something like that. But the non-surgery treatment does well. You're right, it's not perfect, and if it happens a second or third time, you typically talk about surgery. But if you can help 40, 50, 60% of people avoid surgery in the first place, that's generally thought to be a good thing. Surgery is not free, number one, but more importantly, it's not risk-free. It's a very, very long recovery. So just in general, if you can overcome an injury without surgery, that's generally a good thing, and that's largely why I pivoted to regenerative orthopedics. Having said that, yes, there are some people that don't, especially in younger, like your teenagers and preteens, that they have a very high recurrence rate and often need surgery, but a whole lot of people don't, which is why we do that. All right. Vic, what I was saying, that for military questions, join me in the 5:30 show. That is a whole other discussion. The different show, different live stream. All right, Omar says, thank you. You're very welcome. David also, thank you. Single speed, what's the best routine to ease back into running after a calcaneal stress fracture? So I'm a little bit more aggressive than most. I basically, and it depends a little bit on the initial treatment, but calcaneal stress fractures, the heel bone, for those of you not familiar with that, tends to be fairly painful. And so I'll usually do a boot short term for pain. And this is my protocol. This is not medical advice, but with patients, once you can walk pain-free in the boot, then I transition you fairly quickly to walking in normal shoes. Once you can do that without pain, then you can try lightly jogging, even if it's only a few steps. And if you can do that, then you can go a little bit further, do longer jogs, and then full-on runs, increasing your speed, increasing your mileage as you go. But it's a progression, and any step along the way, if you experience pain, you take a step back, and it's this just gradually ramping it up. I try not to, though, even though I say I'm aggressive, I try not to go so fast that you end up starting all the way back at the beginning, and that is where it's a little tricky. But that's generally the rule of thumb. You progress, and as long as symptoms are okay, you go a little bit further. Days in between you take off, things like that can be helpful. Cross training can be helpful. So on the days in between a light jog, maybe you do the bike or something like that. Some other good thoughts. And he or she says, if I can get it to pop up, it's been a month, back to walking, cycling, rowing, uncertain about when to pick up running again. Yeah, that's how I would do it, or the factors I would use. But again, there may be more to it, so always good to talk to your doctor. But that's generally the progression. Can we get and use penicillin polysulfate in the U.S.? Yes, there are some compounding pharmacies that have it, and there are some physicians that will prescribe it. There is nowhere you can go and buy it online. To my knowledge, that would be illegal. But yes, there are some places that do that. Kayvon, knee injury, tore 3 ligaments. That doesn't sound good at all. Had nerve damage to my peripheral nerve during a fall. I'm assuming... typically what that means with, and you are very, very welcome, Kayvon, what that typically means with three ligaments, it's usually a combination of ACL, PCL, maybe LCL. It can be a variety, but I'm guessing that was the peroneal nerve that got injured, and that is a tricky problem. You wait 12 weeks or more for it to slowly come back, but I've seen a decent number of those that never did come back. It's a really tricky problem. You get the nerve surgeons involved fairly early, and sometimes they'll have to explore the nerve, but it can be a problem for sure, and I wish you the best with that. And then Nicholas is a little more in-depth than most people are going to want to hear, but it's basically patellar instability. It's about the depth of the trochlear groove, and there's other factors, not just the patellar groove, but also where the patella sits top to bottom. So some of what he's talking about, this ratio, is determining the depth of the trochlea on the front of the femur. Also, is the patella high, patella alta, or I can't do it with this model, but low, patella baja. And those are radiographic ways to come up with a number to basically show you there's an anatomical reason for patellar instability. And there's fancy tests, both x-ray and CT scans, to try to figure out some of that. And if there is, it changes the nature of the surgery. Instead of maybe a soft tissue reconstruction where it's not on here, but you would reconstruct the medial patellofemoral ligament, when you're talking about anatomic issues, then you're potentially talking bony changes, either moving the tibial tubercle or cutting the femur and rotating it. It depends on the type of abnormality. It becomes a much bigger surgery, but it is much more likely to be successful if you identify those anatomic issues and address them rather than just doing a soft tissue stabilization. So hopefully that makes sense without putting everybody else to sleep or wondering what in the world I'm talking about. Antho, I'm new here. ACL, right and left meniscus tear, or right knee, medial and lateral meniscus tear, I guess. Surgeon told me I'll need the brace and crutches for 6 weeks. Is there any way I can reduce the length? That's really a surgeon preference, and that's true in the United States for sure. I'm sure that's true in the U.S. Do you wear a brace after ACL surgery, and for how long? How long are you partial or non-weight bearing? So I'm not going to tell you things. I would say go with whatever your surgeon says, because there may be factors about your surgery. I was always fairly aggressive, at least allowing touchdown weight bearing and a lot of times full weight bearing pretty quickly if there was no meniscus repair, and tried to do full motion as quickly as I could too. But again, there's a lot of factors, and there's also a lot of surgeon preference. Kayvon, you're very welcome, and Nicholas says thank you as well. All right, that looks like it is it. I'm going to get ready for my show for the military veterans at 5:30, so if you are watching this for that reason, join me on the Veteran Nexus Letter channel. I very, very much appreciate it. Jerry, I will look up that, try to look up that therapy that you were asking about, and maybe talk about that either on the next monthly show or in one of my videos that I'll be recording for the next few weeks here soon. So thank you for sharing that. I will try to find out more information. Those of you watching, I very, very much appreciate it, and I hope this was helpful. And you are, Antho, you are very welcome. And Tang asked, can I give a list of doctors? I can't. I don't know that exists anywhere, quite honestly. A list of doctors and every treatment they provide, I just don't know that would exist. But having said that, very, very grateful that you were here. I hope this was helpful. I look forward to seeing you. I'll be back doing the live show right after the 4th of July here in the United States, Monday, July 7th, 5 p.m. And as always, join me for my regular content throughout the week. Thank